Good afternoon, everyone. Today I am going to discuss about prodrug design and its applications. The concept of the prodrug. Prodrug concept was first introduced by Adrian Albert in 1958 to describe compounds that undergo biotransformation prior to eliciting their pharmacological effects. The prodrug is a biologically inactive derivative of a parent drug molecule that usually requires a chemical or enzymatic transformation within a body to release the active drug substances and possesses the improved delivery property over the parent drug molecule. Prodrug basically establish there are several reasons like to improve the physicochemical properties of the compound, to improve the biopharmaceutical and pharmacokinetic properties of the potent molecule, and of course very important, the pharmacological properties of the molecule can also be increased with the prodrug. If we see the concept of the prodrug design, we are attaching some drug moieties, some pro-moiety with the drug. The pro-moiety can be attached by the linker or maybe directly attached to the parent drug. Pro-moiety, when we select, it should be safe, rapidly excreted from the body, rapidly metabolized, should not produce the any toxic effect. And basically pro-moiety design we are taking on the basis of the disease state condition, where the disease happened, what is the environment, the disease site, all those things we are considering, dose we are considering, and duration of therapy what we require. So this pro-moiety, when with the drug, when we attach and we converting the drug into the prodrug, when the drug is taken, it is going inside the body. After the enzymatic or chemical transformation, the pro-moiety is excreted from the body and drug is having the site of action, whatever we are looking for in the better way. And it is also resolving ADMET issues, all those things. Okay. What are the different challenges that is associated with the parent drug, and we are using the prodrug approach to overcome those challenges? Like if we see that, like formulation and administration, there are various issues like low aqueous solubility, low shelf life, irritation and pain at the injection site, at the local administration site, unpleasant taste, odor, poor membrane permeability, GI irritability, efflux from activated when we are giving the normal drug, like lack of site specificity, lack of distribution, and duration of action is very low. All those things we can consider in the product design to improve its pharmaceutical, biopharmaceutical and pharmacological properties of the drug, so that we will get a better action. What we are doing in the prodrug, we are converting some functional group in the some other group to convert the drug into the functional group that is found in the drug, and which particular functional group we have to convert according to the issues present in the parent drug. So if we see the this particular chart, that C double bond OH group is associated with a lot of challenges when we can convert into the carbamate, amides, esters, carbonates. If we see, if C double bond OH is having the more lipophilicity, but as compared to C double bond OH, other groups are more lipophilic, not hydrophilic. So we have to see the challenge associated with the parent drug, and according to that we have to go for the change in the functional group. If we see the stability of the functional group in the drug, amide is the most stable functional group, and phosphate ester is the most less stable group. And phosphate we are using for the increasing the water solubility. If we see the ester, we are using for increasing the lipophilicity by changing the R group. So likewise, each functional group is having the different opportunities to convert in the different prodrugs. And if we see alcohol is having a lot of opportunity to convert phosphate also, ester also. So if we see, the phosphate is a very commonly used, ester that is very commonly used, amide they are using less commonly because it is more stable as compared to why we are required to convert such drug. So there are certain reasons. If we see, some drug is having solubility issue, so we have to improve the solubility. Some drug is having stability issue, we have to improve the stability. Some drug is having, issue in the taste and odor, we have to change that particular taste and odor by changing the drug into the product, like decreasing the local irritation and pain. And if we see the pharmacokinetic, like absorption, distribution, pre-systematic metabolism, that protein binding, all those things also improve, can be also improved in the product design approach. Pharmacodynamic approach is also like masking the reactive agent to improve the therapeutic index, like increasing the site selectivity or site specificity by modifying the drug so that it will bind to better way in the receptor. If we classify the prodrug in the four category that is published, that mentioned in the paper Current Medicinal Chemistry in 2010, the first type is metabolized intracellular, means such prodrug is metabolizing inside the cell, and again it is classified A and B type. So metabolized at the cellular target site for their therapeutic action, like drug is acyclovir, cyclophosphamide, L-dopa, they are metabolized inside the cell only and near the cellular target. But B type, they are converting by metabolic tissues. It is found in the metabolic tissue nearby, maybe most commonly in the liver, like carbamazepine, captopril, heroin, primidone. So these, if we see type 2, that is metabolized extracellularly. They have again three types, A, B and C. The second type, A type, they are metabolized in the gastrointestinal tract. B metabolized in the circulatory system or other extracellular fluid, and C is near the target cell. But here in the C type, we are using targeted drug delivery system. So antibody directed enzyme prodrug therapy. Next is gene directed enzyme prodrug therapy, ADEPT and GDEPT. So this is the overall classification, but it is mentioned in this. We see the generalized classification of the product. Their product is two type: carrier link prodrug, bioprecursor prodrug. Carrier link prodrug is having pro-moiety attached with the parent drug by the linker, some carrier. But in the bioprecursor, there is no linker. It is directly, we are modifying some functional group which is present in the drug itself. So there are the difference. Bioprecursor prodrug, if you see, it is also having some differences from the carrier link prodrug, because bioprecursor prodrug is always metabolized by oxidative or reductive oxidation only. Oxidation or reduction 2 phenomena is always present, but in the carrier link they are following variety of the metabolic transformation techniques. Hydrolysis is also there, esterification also there. There are a lot of mechanisms there. We can also again classify this carrier link prodrug like bipartite, tripartite, mutual drugs. So bipartite means two drugs we combine together, tripartite with three drugs we combine together, and mutual prodrug means one drug is behaving the pro-moiety for another. So these are the classification, and we are converting the parent drug into the prodrug. But what are those applications? These applications we already studied in the objective of the product slide, but here I summarize it, like improve the formulation and administration. Sometimes we are using some prodrug like phenytoin. Phenytoin we are using for as an anti-epileptic action, but when we take a look by the IV injection, it is having the local irritation, and there are a lot of bioavailability and solubility issues. So we are converting phenytoin into the in the phosphate ester, and it is drastically increasing the water solubility of phenytoin. And now this product we are calling phosphenytoin. Enhanced permeability, if we see, like we are taking some drug in the eyes, local irritation action, like So we are using some drug in the glaucoma, so there are permeability issues. So we can increase the permeability by modifying the drug into the esters. And we can also changing the distribution profile, like we have a cancer in the particular area of the body, or cancer cell is having the reductive environment, and that reductive environment can be used to design the product. We design the product in such way so that it will reach to the cancer site, and by using the reductive mechanism it is degraded into the parent drug and giving the site specific action. And this is successfully done by the scientists, and it is already reported in the lot of literature. And sometimes we are overcoming the toxicity of the drugs like aspirin, like NSAID we say. So NSAID we are converting into the product, and NSAID is having side effect of the gastric irritation when we convert into the product. So like aspirin we are converting in banorilant. So such drug is not having the lack of toxicity issues. So this is overall the this particular presentation. I hope that you understand, and I am sending you this presentation now in the group, so you just give the answer of all the question, and we will discuss the more detail in the classroom. Thank you very much for your attention.